The patient treated in this case today is a 57-year-old African-American female who had worn a conventional maxillary complete denture, opposing an old IMZ implant retained overdenture for the past 14 years. She was very satisfied with her implant prosthesis. However, she was still wearing a maxillary complete denture, and even though aesthetically it was acceptable to her, she was concerned about long-term bone loss and the fit of the denture. She also would like to have the palate removed in her denture if that was possible. Figure 1 demonstrates the high smile line of this patient, and as you can see, the complete maxillary denture certainly is aesthetically pleasing. In Figure 2, we show the preoperative panoramic radiograph, which appears to illustrate good height of bone to accept dental implants in the premaxillary area. So using this and our clinical evaluation of the ridge, as shown in Figure 3, it appears that we have plenty of bone to be able to place 4 implants with maybe a locator, single locator attached overdenture, or maybe a bar retained overdenture. Certainly there's other diagnostic tests or other tools we could use to place our implants. It looks like we have plenty of bone, so maybe we could put more implants in and give her even a fixed prosthesis if that was possible. Figure 4 shows the vertical height of bone. Again, it looks like we have very adequate amount of bone to work with. Figure 5 shows the underside of her properly fabricated, well-fitting conventional maxillary denture, and this denture is going to be used or duplicated to fabricate the CT guide and eventual surgical guide. So we simply duplicate this denture. The laboratory will then use gutta-percha markers, and we will take a CT scan using a very stable, clear acrylic CT guide. Figure 7 shows the CT digital plan, and this illustrates the panoramic cross-sectional and axial views, as well as three-dimensional rendering of the patient's maxilla. Simple panoramic radiographs or periapicals do not give the three-dimensional image achieved with this CT scan. I thought this case was a slam dunk. It looked like we had plenty of bone to work with on the panoramic. However, as we can see in Figure 7, the bone is extremely thin in the premaxilla. I was completely fooled by our conventional radiographs. We had good height of bone, but terrible width of bone. So the difference between a three-dimensional diagnosis, as we see here in Figure 7, versus a two-dimensional diagnosis, even though we did a clinical evaluation and it appeared that we have adequate bone, our decision to place implants in the premaxilla using our conventional techniques would have been wrong. We would not have been able to place implants predictably without grafting the area. Our CT scanning here allows us to make pre-surgical decisions on whether or not we can place implants in a different part of the maxilla. And that's what we'll end up doing. From the CT scan and diagnosing that we made, a surgical guide is fabricated. This surgical guide is a universal surgical guide made by Materialize. It consists of single SurgiGuide keys based on the drill diameters that we're going to use. And again, the size of implants that we're going to place are all predetermined using the CT scanning software. Sleeves are placed in the SurgiGuide to give us direction of each of the drills. Figure 8 demonstrates this universal SurgiGuide from Materialize. The SurgiGuide as seen in Figure 9, is placed onto the maxilla and locked into place using stabilizing pins. This surgical guide does not move once the stabilizing pins are placed, allowing for a very accurate guided placement of the dental implants. So in this situation, the CT diagnosing was critical to our attempt in placing our implants. Figure 10 demonstrates the surgical stent in place with a narrow platform guide used for the 2.0 millimeter Lindemann drill, guiding angulation and depth. The Cybron implant system, which we chose to use in this case, is very simple and precise. The first drill used to initially determine angulation is that Lindemann guide drill. This is a very sharp drill with a very sharp point. The Lindemann drill is positioned to the predetermined depth that was determined using the CT diagnosing, and the Simplant software, which allows us to virtually place the implants before we ever touch the patient. So this Lindemann drill is positioned to the predetermined depth through the 2 millimeter platform key guide. The next two figures here show a 2.2 millimeter platform key positioned into the sleeve, and the 2.2 diameter twist drill is then used to establish depth. As you can see in this system, the black lines are clearly delineated. 7 millimeters, 9 millimeters, 11 millimeters, 13 millimeters, and 15 millimeters to the top of the twist drill. Soft tissue is compensated for with the CT and the universal surgical guide. Figure 15 illustrates a periapical radiograph of the 2.2 millimeter twist drill to the predetermined depth.